Everybody, great to see so many folks out today, in the room and also on Zoom. It's a pleasure to introduce my friend and colleague, Dr. Tonia Poteat, who is visiting us from Duke, where she is a professor in the School of Nursing and co-director of the Duke Sexual and Gender Minority Health Program. Her research, teaching, and clinical practice focus on HIV and LGBTQ health, with particular attention to the health of transgender communities. Her research attends to the role of intersectional structural stigma in driving health inequities and seeks to identify strategies to advance health justice. She certified as an HIV specialist by the American Academy of HIV Medicine and as a gender specialist by the World Professional Association for Transgender Health. She's also an associate editor for the journal LGBT Health and serves on the Department of Health and Human Services HIV treatment guidelines panel. She also founded and co-leads the Intersectional Transgender Health Scientific Working Group. She's going to speak on beyond minority stress, advancing trans health justice using intersectional multi-level interventions. I'm particularly excited about this talk and looking forward to hearing more about the research. Thanks.
Hey y'all. Hi.
Hi.
You don't think we know. Thank y'all for showing up, so I'm not talking to myself. I really appreciate that. And thank you, Aiden, for that great introduction. And whatever you're about to see is his fault because I called him and I was like, what should I talk about? So there you go. I want to start with the land acknowledgement that we are on Lenape land, and also acknowledge that we are in a country that was built on slave labor. And I want us to think about, hopefully some of the concepts I'm talking about today in your own lived experience, think about ways that we can use our lives to undo some of the legacies of structural racism and settler colonialism. And because Google, I looked at, well, what can people do? So I found two organizations that are working locally to address these issues. And I think my slides are going to be somewhere that people can access them if you want them. So what I'm going to talk about is hopefully connected in three different parts. One is to start with like a structure, the framework around which I try to do my research. I have a lab that we call the RISE lab. Introduce you to all those folks at the end. But really, the framework around which I try to do research, and then talk through two of the research in progress grants that I have going right now. One of which is looking at how we link intersectional stigma and discrimination to health outcomes. And the second to what do we do about it? Good? Great. Y'all make eye contact. I love it. Okay. So framework is called Intersectionality Research for Transgender Health Justice, an action framework. Here's the paper. I want to give full credit to the fact that there was 6 to 8 of us that worked for a long time on this framework, led by Linda West at the University of Wisconsin, who is a nurse scientist. I learned a term I've learned recently. Who really guided this work. And then on the next page, there's going to, in the next few slides, there's going to be the actual conceptual framework visual that we created. And I take no credit for that because we are not artists. The framework is really built on 3 theories. One is intersectionality, one is structural injustice, and the third is community engagement. Are folks familiar with each of these constructs? I think you've had other speakers talk about these, so I'm going to go relatively quickly explaining how we use each of them. So I like to outline 3 core tenets of intersectionality that I shamelessly steal from Lisa Boleg, who is the queen of intersectionality research and was here at Drexel for a really long time. So I'm going to do her a grave injustice, but I will do it quickly, so it'll hopefully be less painful. One of the core tenets of intersectionality is the both and concept, and one of Lisa's papers that I really love is once you bake the cake, you can't take out the different components, and it's a much sexier title than that. But that's basically, we are all parts of ourselves all at once, both and perspective. The second, they came together randomly. Okay, the second is that we exist within these structures of power that shape our lived experiences. And some of those structures of power I have listed there are things like our legal system, our financial system, our cultural and religious system. And though we pretend to be a secular country, that is not how our legal system operates. And third is social location. So I like this graph, which is taken from some nice Canadians, because it explains the term marginalized. But for a long time, I heard multiply marginalized. I was like, well, margins of what do you mean? But if you think about power as being centralized, which it is, and people with different social locations are farther and farther away from these centers of power, closer to the margins. Another thing I like about this graph is that on the outside, it talks about the processes that lead to those marginalizations. So things like sexism, racism, transphobia, those kinds of things. We good? Hang on to those thoughts about what intersectionality is when we think about how we apply it to this framework. I always put this slide up when I'm talking to public health audiences because I think public health does a really good job of looking at these social locations or social categories on the left, and a good job of outlining the health inequities and some of the other social inequities that happen. And what we do less well is that piece in the middle, describing those social processes that link the social categories to the health inequities. That makes sense? So we don't like call out racism or call out transphobia or call out heterosexism, things like that, as often as we could. And I think what that leaves us with is people linking certain social locations or identities with certain health outcomes without a really clear understanding of why. Structural injustice is a theory that was developed by Iris Young. And the short story of it is basically our societies are built on unjust systems, that they're unjust structures, and that all that is required to perpetuate injustice is to go along with the status quo, the way the systems were set up. Doesn't require you to do anything special, to be a mean person, anything. Just go along with the status quo, and that perpetuates inequity. And that means that all of us as a member of society have a collective responsibility for making change to those systems. Don't worry, I'm not gonna go through every section of this slide. You're like, oh my God, we're gonna be here all day. I like this because it's a good encapsulation of this whole concept of community-based participatory research. But the short version is that people who are experiencing the inequities that we are interested in addressing and solving should be the ones at the center of defining the solutions and creating priorities. So this is the really beautiful graphic that we developed. The effort was to look at what are these intersectional causes of health inequities and the multiple layers of society in which they operate to lead to transgender health inequities. And I don't think I have a pointer, but you can see transgender health inequities at the bottom. But we didn't want to leave it there like this is the why things are bad. But what do we as researchers, what can we do to address those things when we do our research to lead towards trans health justice? And we recommended 3 things out of that framework that are built upon the 3 sort of foundational theories. When we do our work, name intersecting power relations. So that little circle in the middle, call it out. Disrupt the status quo. Do things differently, not go along with the structures that continue to perpetuate inequities. And to center embodied knowledge, along with the concepts of community engagement. We good? All right. So the next couple of slides are really going to look at when we're thinking about trans communities and trans health inequities writ large, what are some of the interlocking systems of oppression? And I love that these 2 graphs side by side, because you might notice some overlap in where things are difficult, right? So there's many states and many jurisdictions in the United States that have jumped on a bandwagon of putting forth really negative anti-transgender laws related to access to medical care, access to participation in sports, things like that. You'll see that there is similar legislation happening. This is from 2 years ago? No, last year, April 2023, of states that are adopting measures banning critical race theory in education. And I always think that is such a such a powerful lesson in messaging, because critical race theory is not taught in primary schools anywhere. I don't think theory is taught anywhere. So what it allows them to do by calling it critical race theory is to ban books that provide accurate representations of the historical racialized context of this country. And those places are overlapping, not by chance, right? If we look at the status quo in terms of where my focus is as a health researcher, we see health inequities, and I selected these on purpose because it's related to the studies I'm going to show you later. But we know that there is huge differences in experiences of stigma and discrimination by gender identity. That not surprisingly, that this is associated with differences in mental health by gender identity. There's growing evidence that there are differences in cardiovascular health, which we know are impacted by these social factors, as well as by mental health. And in the area where I do a lot of research, but I'm not going to actually talk about HIV today, HIV research today, there are extraordinary disparities in HIV by gender and race. So if we're going to say we're going to start with centered embodied knowledge, what do communities, trans communities, say we should be doing in research? One thing we do is go to the literature because really fantastic people have asked communities what they want their priorities to be. And I love the title of this article, Focus More on What's Right instead of What's Wrong. And I think public health has a really strong history of focusing on what's wrong and then how to fix it versus what's right and we can build on. This article also encapsulated some of their qualitative findings into these three categories. People want to see research on the complexity of their identities, not to be reduced to one aspect of who they are. People want us to make visible the discrimination that we talked about earlier, and they want us to measure both resiliency and I would say even resistance and not just disparities. More recently than this article is a great article that was published by a group of trans health researchers, and by trans health researchers I mean they are trans and they do health research, talking about why this is important for all of us and how community engaged health equity research can really move us all towards justice and pushing back against the structural violence that people are experiencing. And then on a minute level, the next study I'm going to talk to you about went to the community advisory board of a study that we were working on already and said, okay, I have this idea for a research study that's with people with HIV, but not about HIV. What do you think? And they said, we are more than HIV. So yes, they were interested in that. And that's going to guide us to the next study I'm going to talk about. And this is where I'm actually going to link what I'm talking about to the title of the talk, Beyond Minority Stress. Have people heard of minority stress before as a concept? It's really popular in terms of an explanatory model for LGBTQ health inequities. This is a very simplified version of the model. Basically, people experience some marginalized social status related to gender identity or sexual orientation. This creates unique stressors related to that, from experiences of stigma and discrimination that are external or distal to experiences of internalized stigma, which are, of course, proximal because they're internal. And that these are the things that lead to negative health outcomes. Access to resilience resources like community, social support, coping resources can mitigate that effect. So that's the most basic definition of the minority stress model. I would say in my land, when I think about minority stress, I replace it with these really long words. Intersecting oppressive social processes embedded in systems of structural injustice. Same thing. We're going to call it minority stress. But what this study really sought to do is to explain this little black box right here. So how do we get from, I experience a lot of minority stress, to I have disparate health outcomes? Sort of a mystery, right? There are other folks who have been doing great research in this area that are not public health people, and hopefully we're coming together more to help understand how these inequities become embodied. Part of it is obviously structural. You experience discrimination in healthcare, you have less access to healthcare, you have poor health outcomes. But there are other ways in which inequities become, social inequities become embodied. I am actually, going to walk you through this one. This is the framework behind the study that I'm going to describe to you. The study is with Black and Latina transgender women living with HIV. They experience, we start on the left-hand side with this lovely circle. It starts with experiencing a multitude of isms, for lack of a better word. Racism, HIV stigma, transphobia, sexism, all of those things. They also experience environmental circumstances that we all experience, like The pandemic was horrible for everyone. We all experience it. So there's the general stressors that everybody experiences and the unique stressors at the intersection of those multiply marginalized identities. And that's the middle part with all the stressors. And of course, similarly, the resilience resources. What we wanted to understand is that arrow that leads, from the stressors to the health outcomes, how does it become embodied? And folks who've been doing research on things that are sometimes called weathering, sometimes called allostatic load, are looking at how these experiences become embodied through a process of physiological dysregulation. So the simplified version that is listed here and called allostasis is we experience stressors, be they physical, psychological, emotional stressors. There's a dysregulation that happens, and then we return to baseline, right? True for all bodies, as far as we know. But what if you have daily, repeated, everyday experiences of stressors? Then that regulation stops happening. Your body doesn't have the ability or the time even to respond and re-regulate, and that leads to chronic dysregulation of our physiological systems, and that is called allostatic load or allosteric within this slide. I'm going to call it allostatic. So that was the framework behind the study that we ended up calling Light Plus. You can see the NIH title. Oh, you can't. I will read the NIH title to you. Biopsychosocial mechanisms linking gender minority stress and HIV comorbidities. Never call your study that. We ended up calling it Light Plus because it was building on a previous that was a longitudinal HIV focused study with transgender women who were not living with HIV, following them over time. This study was with transgender women who were living with HIV, so we called it Light Plus. You can see the amazing people I got to work with down at the bottom, and I want to give full credit to all of them, as well as some really smart folks who study allostatic load. That is not my training. So we have scientific advisors who have expertise in this area. We had 3 aims for the study. We wanted to look at the relationship between stigma and chronic stress over time. We wanted to identify the pathways that link those 2 things, as we've been talking about, and explore chronic stress as a mediator in the pathways that link stigma and HIV comorbidities. Sorry, I'm gonna arrow with my hands. And the role of gender affirming healthcare in mitigating, potentially, having no effect potentially, or making worse those outcomes. Be good. I'm a call and response person, so I have to. All right. So yeah, we did a lot of measures. I will say this was my first RO1, so I did not have any restraint in terms of asking people way too many questions. This is like a 45-minute to hour-long interview about the most depressing things to humankind. I do not do that anymore. But we asked a whole lot of questions. We did want to look at all the different ways that people might experience stigma. Stigmas related to their marginalized identities. We wanted to understand their coping and social support. We wanted to look at their mental health outcomes because that was one of the HIV comorbidities we were looking at, and we wanted to look at their cardiovascular health. We also wanted to understand that obviously this is in the context of someone living with HIV. We're looking at physiological systems that get dysregulated. It would be really important to understand what does their immune system look like. So CD4 and viral load. And then we use these clinical measures you see on the right to look at cardiovascular health, but also to create this measure of allostatic load. And I'm going to show that to you on the next slide. And you can like boo or cheer or think of better ways to do it, but this is the common way that it's done. We also wanted to look at salivary cortisol patterns, which is one of the measures of chronic stress. So for the subset of participants who were willing to spit 3 times a day over the course of 2 days for us, and that's asking a lot. I went to spit camp and they made us do it, and I was like, oh, this is a lot less pleasant than one might think. And nobody even thinks it's pleasant to spit 3 times a day. We also collected qualitative interviews to understand people's experiences of their own lives, how they describe their experiences of stress, how they use hormones over time, and their experience of their mental health. This is how we measured allostatic load based on the input from our scientific advisors. We have 14 biomarkers listed there. Some are endocrine biomarkers, some are inflammatory biomarkers, some are cardiovascular biomarkers. And you create an allostatic load index or score based on how many of those biomarkers are dysregulated, right? So if you have, in this example, 6 dysregulated biomarkers and you have a score of 6 out of 14. We also wanted to take into consideration that for some folks, for example, if we're looking at hemoglobin A1C, that is a measure of glucose control. So if someone has diabetes and it's well treated, they might have a normal A1C, but their system is clearly not regulated because they require medication. So we would then give that person a point for that, even if they were on medication, even if that system was normal in our blood test. We good?
Yep.
All right. Awesome. Yes, yay, interaction.
Sorry, is that diabetes requiring insulin, or like could that include type 1 diabetes as well as type 2? Or
Yes, any dysregulation, yeah, absolutely, thank you. All right, we got a clinician in the room. All right, the design of the study was to follow participants over 2 years. I have a whole talk on all the things that can go wrong in studies, because the study was like all the things that could go wrong. Because this was my first R1 and it's still going on. So COVID kind of happened and there was a brief interruption of several years in the middle there. So we are still collecting data. But the plan was to follow each participant for 24 months. And you can see that how we collected data there. We wanted to see people every 6 months. We were collecting clinical measures and laboratory data every year, baseline 12 and 24 months, and then the qualitative data and survey data at the 6 and 18 months. We recruited participants from Washington, Boston, and New York. We worked with LGBT community health centers. So we worked with Whitman Walker in DC, Fenway Health Center in Boston, and Hannelore Community Health Center in New York. Our goal was to recruit 200 people. At 108 people, that was the maximum we were going to get unless we wanted to continue the study until my retirement. Baseline indicated, not surprisingly, that people experienced incredible structural oppression. If you look on the right-hand side, the right table, for example, over 2/3 of the participants had ever been homeless. The mean days with no safe place to sleep in the past 30 days was almost 5. People reported experiencing at least 1 or more material hardship, and over 40% of the participants sometimes or often ran out of food. So we can see that the structural oppression was apparent in our data. You'll also see that the participants' average age was 41, and this was important because we're looking at cardiovascular outcomes. And the older you are, the more at risk you are for cardiovascular disease. But also the measures, the algorithms that give you an estimated risk for a cardiovascular event are validated in people age 40 and over. So we were deliberately looking for older people. At baseline, we saw, I won't go through each of these lines, but we saw a lot of self-reported depressive symptomology, PTSD symptomology, as well as self-reported diagnoses. And the allostatic load index mean range was about 3, and anything above 2 is really considered high in the literature. I also won't go through all of these, but we saw probably average for people living with HIV, dysregulations in their cardiovascular systems related to blood pressure, cholesterol, diabetes. Almost 1 in 5 participants were taking a statin, meaning that they had high enough lipids that they needed to take that. This is before the big reprieve study. For those of you who do HIV work, that said the whole planet should be on a statin. And then you can see recommendations for discussing going on a statin are having a heart disease risk score, ASCVD risk score greater than 7.5, and 24% of participants were there. And a score of 10 is like, don't talk, persuade, right? And that was 14%. I will skip a whole bunch of in-between steps and take you where we landed in terms of our multi-level model, looking at our cross-sectional baseline data. So this is not the longitudinal findings, because as I mentioned, we are still collecting data, but this was our baseline data. And we saw relationships that we expected, right? When we're looking at associations with allostatic load, that sort of chronic physiological dysregulation. Obviously, the older we are, the more chances for our body to get things wrong, right? So we see more dysregulation, that's expected. We also saw less dysregulation the higher someone's score on a coping scale, which is what we expected to see. What we did not expect to see And what really annoyed me, but I'm trying to see as an opportunity, is that we saw a negative relationship between allostatic load and everyday discrimination. Now, we had 1,000 different measures, or 5 different measures of discrimination in our study. We looked at HIV stigma, we looked at racial stigma or experiences of racism, we had a transphobia scale. So I looked at each one of these separately, and all of them had a negative relationship with allostatic load. Exactly, and I was like, well, I'm not going into the world telling people that if you treat trans people badly, their dysregulation will be better. Let's go for it. Like, that's not what I was gonna do. So I wanted to understand what is actually happening. Why did we see this difference? We had a lot of theories. We're currently working with 2 right now. One obvious one is it's a cross-sectional analysis, so we will need to wait for the 24-month data to look at longitudinal results. But also, when we're measuring our discrimination measure, we're asking people about their experiences, right? Their interpersonal experiences of discrimination. We have this whole conversation about how these structures of power really shape our experiences, but we are not measuring that in this model. So maybe we're measuring the wrong thing. The second piece is we are not even actually measuring people's experiences. We're measuring what people are willing to tell the interviewer about their experiences, right? And that is a different thing than someone's experience. Let's go down the first road first. What are we gonna do about this potential measuring the wrong thing? You can see that the cities were DC, Boston, New York. Their HIV laws and policies really didn't vary between those sites. We couldn't really look at that. Their gender-related laws and policies, their protective laws, didn't really vary between those places. So we couldn't look at that. We know that racialized segregation and gentrification is a measure of structural racism, and it varies at the census tract and zip code level. So that is what we're working on right now. There's great people who do this work that we invited to be partners on this, and they are pulling together these measures that we're going to merge with our data set and look and see where that takes us. What about the second piece? What about, does self-report itself have a meaning? Zachary Du Bois is one of the scientific advisors and does a lot of work around chronic stress in trans communities, especially looking at salivary cortisol data. And he found a very similar result, at least when I talked to him, because I don't do cortisol research. He said, oh, that sounds very much like what I thought. We saw that the cortisol awakening response was negatively correlated with people's experiences of stigma and non-affirmation of their gender. And we had a total nerd out, great couple of conversations talking about what this means. That if we think about being able to call out stigma and discrimination as an act of resistance, an act of taking agency, it is a resilience resource in that way, right? And I pulled this quote from Sims and Shooten that describes that resilience can also mean resistance. It can reflect agency, identity, and ownership of one's experiences. And that might be what lowers someone's allostatic load. Not the fact that they experienced it, but that they're willing to call it out when asked. So this is work in process. What are we doing next? I mentioned we're going to merge those structural variables to look at segregation and gentrification and look for interaction between these structural and self-report measures. And then we're going to look at the longitudinal data to see if this inverse relationship lasts over time, and then try to understand that a little better with our qualitative interviewing. We're almost done with data collection. We expect it to be done in just a few months, but we've already started the process of dissemination for a couple of reasons. One of the things that took me a painfully long time to learn around community dissemination is that people don't want to come to a community dissemination workshop. I don't know if you've ever had one. It's not things people show up to in my experience. It's like, hey, you're going to share some data, please show up. And they're like, they don't come. What people finally told us is they wanted to get the results back in the way that they gave them to us, right? We met with them one-on-one and asked them a bunch of questions. Why can't we then give that individual back their information? So one of the things that we're doing is sharing some of the key laboratory values for each individual back with them when they come back for their follow-up visits. But we also have a newsletter that we try to send out a couple of times a year that sort of summarizes what we've learned so far, who's in the study, what we're seeing, those kinds of things. So that kind of dissemination to the participants is ongoing. We've also used the baseline data to sort of participate in an ongoing conversation around these clinical algorithms that are shortcuts that clinical providers use to make decisions, and sometimes are invisible to us. So those of you who have been paying attention to sort of how we measure whether or not somebody has kidney disease has included race in that algorithm for a long time. And there are a lot of people calling into question, and at least the clinic where I work, people have included a measure that does not include race. And what I haven't heard people talk about is that gender is also, or sex, because people don't know the difference when they're using these algorithms. But both are artificially binary and socially constructed, and we don't know how that affects what we're looking at. So these papers really look at that. I could go on a long tangent about that, so feel free to ask me about that. But it's like, what are we measuring when we put sex in these? Are we really think that like genitals has an effect on your heart disease risk? Do you think it's hormones? Do you think it's what? What do you think it's sexism? What are we measuring when we put these? So that's what these papers are calling into question. And we're planning, hopefully, to tweak our aims a little bit based on the data that we have to answer some of our research questions. I'm gonna pause there because I'm very caffeinated and I feel like I'm talking really fast. So if people have comments or questions so far,
Sorry, me again.
yay you.
So I was just thinking about what you were talking about with resilience and everyday discrimination. Did you look to see how everyday discrimination and coping were associated, and maybe look at sort of interaction models to see if there were differences based on whether or not they also had high coping?
I'm gonna go back. We put them in the same model, but we did not include, I'm sorry, please forgive me if you have seizures. We did not look at an interaction term, but actually that's a good suggestion, so thank you. Yes.
I had a similar question related to everyday discrimination, because there's no gold standard. Or first, pause. Thank you. This is amazing. Like, also Southern, so I'm like, greetings. But was kind of curious, because there's no gold standard on how we use the everyday discrimination scale. So sometimes folks will think about like have theories on how it's operating in that space. So is it like each additional experience is like a count? Or are you thinking of it as like a threshold effect, and that like there's some number of experiences that folks have that ends up impacting their health?
I'm so glad you asked this question. It makes me feel better about the inordinate amount of time I spent thinking about measures. So we found a measure, a way of calculating everyday discrimination that they call the chronicity scale. So it took into consideration, and we asked people how frequently do you experience this, and then we like do a count, right? So instead of that, the way that we measured it took into consideration the frequency with which people experienced each of the things on the scale. So that's how we didn't have a threshold effect, but we did try to look at chronicity in that way. Thank you for asking that. Yeah. Yeah.
Question, where are you with your fall data? Like, and did you ask about some of this? And I'm assuming you did. So like, how does that help unpack what you're thinking about here? Or is that TBD?
Yeah, well, it's sort of TBD. So we put into the grant that we would do two sets of interviews a year apart. So the first set of interviews are done, and those are really focused on what are your experiences of your gender over time? What are your experiences of your mental health? What has been stressful in your life? And the second set of interviews is with this fantastic graduate student, Manat Malik, who is really looking at trying to develop a measure of intersectional strength. And so she's asking people about what gives you strength? What makes you strong? How do you survive these things? How do you resist? So no, is the answer to your question. I would love if somebody had time and energy, we could probably recruit some of these participants to ask those kinds of questions. But we didn't know that this was gonna happen, so we didn't really plan for that. Yeah.
Great work. I'm so excited to see that some of the results coming out. And one thing I'm curious about around this question on discrimination is considering that it might not be a linear relationships. Like I think there's some really interesting work. I think like Kate Bright, Nancy Krieger, and some other folks where you see people who report the lowest levels of discrimination and people who report the highest levels. That it's like a J-shaped relationship, which makes sense when you think about it in terms of like what you have to do to think you don't. If you say you don't experience discrimination, like
What do
you're
you have to
probably
do?
surprised. So I'm curious if you thought about that or looked at that as well.
this is the best audience ever. I did not include these slides, but I have about 5 slides where we plotted the discrimination scores on one side and the outside load on the other, and it is like the weirdest shaped curve I've ever seen. It like goes up like this and then does a this, and then it goes flat like this. So I couldn't figure out how to model that. I talked to like 3 statisticians. We're a quadratic thing, like what do you do? We don't have enough participants, unfortunately, to do structural equation modeling, because that's what I would love to do with this data, but you are right, there is a more complex relationship there than what can be visible in a linear regression model. Asking all the good questions, getting all my tea, yes.
It's like, that means that it's probably being measured pretty well, because it is a complex. Right, the fact that it doesn't fit into any normal distribution, maybe it's a good way.
It could be, yeah. I mean, it is like a very old validated, so we could try to pick one.
Can you talk, oh, sorry, it's a great talk. Polite, sorry.
Are you training the people next to you to?
That was my pick.
Okay.
Can you talk a little bit about cortisol? Do people really follow the 3 times per day?
Do you come to our study team meetings and just ask all the questions?
As someone who just avoided cortisol altogether because of how complex it is, I think this is amazing that you know, I tried to collect this information, and I would love to hear more about it.
Yeah, I feel like I can give up
Obviously, of
a
course.
whole other talk on the caliber cortisol research.
Yeah.
We deliberately had it be a subset of people, so we only invited like 50 people, and we had all the exclusion criteria, like you couldn't use like nasal sprays that had cortisol in and all those kinds of things. And then we had like instructions about not to eat or drink and all these kinds of things. And we had a form that people were supposed to fill out if they did eat or drink or smoke. And then we tried to incorporate this all into our compliance, a compliance variable that we're including in the models. But the model is pretty small because 50 people were invited. Probably 40 people, 45 people actually said they did it. And then there were some samples that did not have anything in them or had something that was not saliva in them. Right? Right. And there's this sort of like, you're supposed to take the first sample, like right when you wake up before your feet touch the floor, and like everybody of course has their little spittoon next to them by the bed and does that perfectly. And then the next one 30 minutes later before you brush your teeth or smoke or eat, and then another one at bedtime. So we are seeing all sorts of interesting curves, and we are trying to sort out now how much of it is like non-compliance with the protocol and how much of it is like people's lives are really dysregulated. So
Also, in case you haven't included this into your cortisol calculation, I think cortisol dynamic range, just like from 30 minutes to before bed.
yeah,
I've heard it's like a newer quantification of cortisol that can be associated with a lot of, you know, social factors, in addition to AUC and awakened scores.
thank you for saying that. 'Cause
I
we're
can
not
tell you
using-
the paper, yeah.
We're not using AUC because some of our curves literally are like this.
Right.
But we are using the cortisol awakening response, the wait to 30 minutes, and we're also using that separate measure from 30 minutes to bedtime. So yeah, I will be curious to see now if
Yeah.
we see that.
I've heard it's better than.
Maybe we will see if it's better.
Yeah.
Now I'm worried about running out of time, so I'm gonna speed you through these things. Is that okay if I like go to the next part? Yes. Okay, so we are desperately trying to understand how stigma leads to these health inequities. But even so, like, what do we do about it, right? So the next part I want to talk to you about is a study where we're trying to figure out what to do about it. Beating a dead horse here. And where did that term come from? Why are we beating dead horses? I don't know. But we know that there are structural impacts of discrimination. So we have in the minority stress model, we have these like general stressors, and then we have these minority stressors, but they are actually, in my mind, not separated. If you experience stigma and discrimination, so you drop out of school early, so you have a lower education, so you have trouble getting a job, then you're gonna experience more poverty, even though poverty is a general stressor. So it's really good. And we see that when we look at these outcomes related to unemployment, public assistance, poverty, and housing instability. We know that the pandemic did not do us any favors and was especially difficult and hard on trans communities. There was already high rates of psychological distress and suicidal ideation, and this up to 41%, and this has been true in multiple studies taken over periods of time. We know there's elevated prevalence of poverty, and we know that during the pandemic, based on data from the Williams Institute, trans people were twice as likely to lose their job early in the pandemic, and also less likely to be rehired. I don't have that on the slide, but less likely to be rehired once businesses opened up again. What was amazing is that the trans community responded in like beautiful and brilliant ways. And I just have a couple of the interventions that the National Black Trans Advocacy Coalition did during the height of the pandemic, but there were multiple organizations that did this kind of work. And I'm mentioning them because we partnered with them. They had long peer support program, connecting people with jobs, social support, and they have these community grants that they provided people during COVID-19. So you contact them if you were having like I need some money to like get through the next whatever till the government check comes or whatever happens, and they would provide those emergency grants. So I was thinking, I really wanted to partner with BTAC because they're awesome. And I was thinking about the minority strength model again and how we focus so much on these distal and proximal stress processes related to someone's identity, but we don't focus on these general stressors and what kind of coping and social support can help people deal with those general stressors and how that might make a difference in reducing health inequities, even if we weren't focusing specifically on stigma and discrimination. So that's how we came up with the aims for what we ended up calling the CARE study, creating access to resources and economic support. Andrea Works is a brilliant person for coming up with study names, so she designed it. And basically, our argument was that the COVID-19 pandemic had a huge impact on people in terms of their material well-being. And we wanted to look at whether monthly micrograms with or without peer support would make a difference in people's mental health outcomes. You good? And you can see our official aims there. We wanted to look at the efficacy of those interventions. We wanted to look at the mechanisms by which they work. And we wanted to understand for people who participate in the intervention, what did they do with their money? How did they feel about the intervention itself? And did they think it was something that worked for them? I am not good with the like placebo arm, and you can't placebo money. So our quote unquote usual care arm were people who got one micro grant. But we also made sure that they had access to other kinds of information that we thought would be beneficial to them. And this is based on a study that we did years ago in St. Louis and Virginia, where we did qualitative interviewing with trans people experiencing material hardship and asked about what would you want to see in a financial intervention? What is the kind of stuff that you need? And people talked about, we added protecting your money because we're going to give people money, going to think about like, don't let somebody who's sweet to you to get your money. But we also looked at how do you open a banking and checking account, and how do you do that specifically as a trans person whose ID might not match, who might experience discrimination at the bank. What are your options? How do you create a budget? How do you set aside savings? Things like that. And then, so those we've already created and are available on the website. But we've also, I think he lives in Philadelphia, found a trans financial person who's like super committed to making sure that trans communities in particular have access to financial information, and is going to create the final video for us based on feedback that we're requesting from the community advisory board about if you had a financial advisor to talk to you, what do you want them to tell you? And these are the three arms that I mentioned, the single micro grant arm, and then the other two arms are receiving $150 every 6 months, and the third arm is also receiving a peer mentoring intervention that is based on two trans community derived peer mentoring interventions. So Healthy Diva was developed by Jay Sebelius in collaboration with trans women of color in San Francisco. The Akani Mentoring is the Black trans masculine intervention that was developed by BTAC. We met with Jay and Carter, who runs BTAC, and had an adaptation workshop, and ended up coming up with the sessions that you see on the right that really start with the first session where people identify what aspect of my life do I want to see change in. And then through the course of the 6 different sessions, help people develop skills for helping them meet the goal that they set for themselves. And it does not have to be a financial goal at all. We also developed a resource guide We originally had developed it for the peer mentors to be able to refer people to resources, and then I thought, well, I'm not a hoarding access to resources kind of person, so we posted that on the website for anybody to have access. But in particular, the peer mentors can use that if they're having a peer mentoring session and it's clear that the person needs resources that are beyond what peer mentoring support can provide. We are also asking people, you can see our little explanation on the right, we've included some resources that we know are transphobic. But we know that some trans people have used these resources because that's all that's available to them. So if you need housing and your choice is sleeping in the snow or sleeping in a place run by homophobes, you might want to sleep in a place run by homophobes. And then we ask people to share if they know of resources that aren't anti. Oh, we also want to make sure that peer mentors got support. So some of the evidence we've had over time is that trans people who provide peer mentoring support are mentoring people for whom they are experiencing the same hardships, right? And that can be really difficult psychologically in many other ways. So they have not only a supervisor, but they have a clinical supervisor or a clinical clinician who's a non-binary person who provides every 2-week sessions with them. And then because BetterHelp has a relationship with BTAC, they provided vouchers that the peer mentors can use for individualized therapy. So we really want to make sure that we're not like traumatizing anybody in the process of doing our research. We're following people over the course of a year. We're randomizing them to one of those 3 arms, getting their baseline survey, doing their follow-up survey 6 months later when the intervention ends. And then we want to see, well, what happens after the intervention ends in the next 6 months? So we have a 12-month follow-up after that. Because I'm a big lover of mixed methods research, we are also collecting the qualitative data. Oh, I don't even have that here, do I? Oh yeah, at 3 and 9 months. And we're doing a text-based survey. I don't know if it's listed here at 3 and 6 months, asking people, so what'd you do with your money? And have you met with your peer mentor? How's that going? Those kinds of things. We launched the study in January. We did a soft launch in November just to sort of figure out what is broken before we started inviting more people. But our main launch was in January. And you can see we have sort of, I hate that word, tailored or targeted interventions based on feedback from BTAC. They're like, you need to provide some information that says you know something about what's happening with the trans community, and then invite people to participate in that way. I want to spend a little bit of time here, thank you, Kelly Court, on talking about how we are recruiting people. So this is an online study because we're recruiting 360 people. Right, for bots, scammers, trolls, the whole planet. So after thinking about some of the challenges of that and knowing that we didn't want to just like post on Facebook and invite people to participate in a study and use money, and all you have to do is say you're trans, we didn't want to do that. We have a process for engaging with community organizations. We're building a network and a list of community organizations that we reach out to, have a call with, explain who we are, ask them if they want to participate. If they say yes, we offer them both opportunity for them to share the study with their constituents, but not outside of their constituents, just their constituents that they know or believe would be eligible. Offer to make their organization visible on our website, acknowledge them during dissemination, and make sure that they're the first to receive the study findings before any other kind of broader dissemination. So that is our process for that. I'm almost done. Then in terms of what does this have to do with where I started in terms of intersectionality research for trans health justice? We are trying to center embodied knowledge by making sure that the intervention itself is something that builds on what the community itself created during a time of crisis, and that we are partnering with trans people and trans community members and trans organizations to implement the study. And BTAC said that they wanted to be a full partner in the research landia. This one option would be to say, we know that we're equal, equitable partners in this, and you're going to be a consultant on the NIH grant, so you don't have to do all the painful like federal wide insurance and all this kind of extremely painful stuff. They wanted to be a full partner. They regret it now, but they are doing it. Carter actually told me, he's like, did I say I wanted to do this? I was like, you did. We were trying to disrupt the status quo, both by that kind of partnership, but also in terms of the science, looking at these general structural stressors instead of focusing so much on minority identities and making sure that instead of a study that's focused so much on HIV, regardless of your HIV status, you can participate, regardless of your gender identity, you can participate, as long as you're under that trans umbrella. And that we're naming these structures of power in terms of discrimination as a fundamental cause of why we see these structural disparities and trying to intervene at a structural level with the microfinance intervention. So I did try to leave a couple minutes for questions. I want to acknowledge, obviously, BTAC is our great partner. The study participants have been awesome. Acknowledge the other partners that we work with in terms of the community health centers and things like that. And also, nothing happens without the awesome people in the lab. So this is graduate students, postdocs, staff, consultants, who allow me to stand up here today and talk to you about the things that our lab is doing, which they are really still doing while I'm standing here talking to you right now. So I want to make sure that we get props to them. So thank you for letting me speak through that, and I'd love to talk to you more.